This is the first in a series of presentations on the topic of disorders affecting the diaphysis, metaphysis, and the physis in veterinary patients. The first two presentations are on growth disturbances in dogs, cats, and horses, and so you will benefit by reviewing the normal appearance of the skeletally immature patient. The intent of this presentation is to describe the most commonly encountered growth disturbances identified during radiography of long bones in the dog. There are many growth disorders that you may have the chance to encounter, and we will not have time to discuss them. At that point, you will need to use the skills that you've learned in your courses to identify and describe the lesions, and then have some good resources that you can search for differentials or reach out and consult with a specialist. By the end of this presentation, you should be able to recognize and describe the radiographic findings of hypertrophic osteodystrophy and Panosteitis. Hypertrophic osteodystrophy, also termed HOD, is a systemic illness with resulting bone lesions that involve the metaphyses of long bones. Particularly the distal radius, ulna, and tibia are involved, and these are usually bilaterally symmetric lesions. The severely affected patients may actually have fever, depression, anorexia, and they are reluctant to stand and walk, and usually their metaphyseal regions of their long bones are swollen, warm, and painful. This typically affects younger patients between 2 to 6 months of age, and large and giant breed dogs are at risk, and I've listed the specific breeds that are really overrepresented. Histologically, there is a neutrophilic inflammatory response with necrosis, hemorrhage, and osteoclastic activity. This osteomalacia disease is of unknown etiology. Several proposed etiologies include oversupplementation of minerals and vitamins, vitamin C deficiency, and even a link with infection of respiratory diseases, including distemper, has been proposed. Pathologists do more recently referred to this disorder as metaphyseal osteopathy, but in our course, we were going to use the term hypertrophic osteodystrophy. Because of the osteoclast activity and the necrosis, the primary and early radiographic finding is of a transversely oriented radiolucent zone in the metaphysis, parallel and adjacent to the physis. So again, this is kind of a lytic lesion. If we look at this image on the right, in the distal radius and distal ulna, we can see these transversely oriented radiolucent zones that are within the metaphysis, so areas of osteoclastic or lytic activity, and they are adjacent and somewhat parallel to the physis. Sometimes you will see a thin margin of sclerosis in the metaphysis adjacent to these zones of lucency. And then later on in the disease process, we can see what is termed cuffing of periosteal new bone that is adjacent to the metaphysis. This patient has a small amount of this periosteal cuffing adjacent to the metaphysis in the distal ulna. Note that this cuffing is distinct and separate from the cortex, and the amount of periosteal cuffing depends on the severity and duration of the disorder. This patient also shows extracapsular soft tissue swelling at the level of the metaphysis, which is quite common and is palpable. The findings are fairly pathognomonic for hypertrophic osteodystrophy. However, in these young patients, especially if they are septic, a differential for this radiographic appearance may be hematogenous spread of osteomyelitis. Premature closure of affected physis or adjacent to the lesion may ultimately occur, and that could lead to an angular limb deformity. So that is one sequela of hypertrophic osteodystrophy, and you may wish to discuss this with the owners of your patients when you diagnose this disease. Here's an example of a 6-month-old neutered male German Shepherd dog who has hypertrophic osteodystrophy, and this is fairly early on. The images in the middle of the slide here are the same as the labeled images on the right side of the slide. This patient has these transversely oriented radiolucent zones, most evident in the distal ulna, with a little bit of metaphyseal sclerosis and extracapsular soft tissue swelling. If you look at the distal radius, there is a very faint radiolucent transverse zone adjacent to that physis. And again, notice that these are parallel to the physis. If you suspect hypertrophic osteodystrophy in one of your young patients, a clinical tip is that the distal radius and ulna are often the first site of involvement. So having bilateral antebrachial radiographs can be beneficial for you to initially evaluate for this disease. In some patients, there are other sites that can be affected, and those sites include the costochondral regions, the metacarpal and metatarsal bones in their distal metaphyses, and even the proximal humerus. I've seen it in the femur and the tibia, as well as the craniomandibular regions. This is the same patient as on the prior slide, our 6-month-old neutered male German Shepherd dog. And if you look at these distal ribs at the level of the costochondral margins, these ribs are enlarged down here and flared, and that is involvement from hypertrophic osteodystrophy. Here's a different patient. This is a 5.5-month-old intact female Labrador cross who presented with unwillingness to walk. And this patient has evidence of early hypertrophic osteodystrophy in several bones. So this is our craniocaudal view or DP view of the carpus distal antebrachium. And if we look at this distal radius, we can see the transversely oriented radiolucent zone, also a faint one here in the distal ulna with a little bit of soft tissue swelling, not very much metaphyseal sclerosis. In the patient proximal tibia here, there's also this radiolucent zone adjacent to the physis within the metaphysis, even in this proximal fibula. So again, it's going to be important for you to remember what the actual physis looks like so that you can see this adjacent radiolucent zone. And then here's the distal tibia of this patient where there is a fainter radiolucent zone and associated soft tissue swelling. So this patient is early enough that we don't have the metaphyseal sclerosis and there is no metaphyseal cuffing. This slide shows 3 different patients at 3 different times within the course of this disease, hypertrophic osteodystrophy. So here's a lateral view of a stifle, and in this patient, this is fairly early. Here's our normal physis, this kind of wavy physis of the distal femur, and adjacent to that is this transversely oriented radiolucent zone that is, again, paralleling that wavy physis. There's probably a little bit of metaphyseal sclerosis. He also has the proximal tibial metaphysis showing this transversely oriented radiolucent zone. This patient is further on in the disease. This is a lateral view of the antebrachium. There's a very faint radiolucent zone in the distal radial metaphysis here with more associated metaphyseal sclerosis. And it's less evident in the distal ulna as well, also has that metaphyseal sclerosis, and there is a very small amount of periosteal cuffing. Now this radiolucent zone here, that's a different disease process. This is a retained cartilage core that can sometimes happen. We're not going to talk about that. So again, we're looking at the transversely oriented radiolucent zones adjacent to the physis. And then here's a patient where it's more chronic and resolving. And if you notice in this patient, we no longer have the transversely oriented radiolucent zones, but we have more of that periosteal cuffing and more metaphyseal sclerosis with still some associated extracapsular soft tissue swelling. Now, ultimately, hypertrophic osteodystrophy will go on to completely remodel, and unless there is subsequent premature closure of a physis near the area of the disease, we will not be able to generally tell when they are adult that they ever had this disorder. More commonly, you will run into panosteitis. And panosteitis is a self-limiting idiopathic disease that affects the medullary cavity of the long bones, so predominantly in the diaphysis, but can be down toward the metaphysis in the dog. This occurs at a little bit older age and even goes on to older kind of almost skeletally mature patients. So it'll occur between 5 and 15 months of age, and it may actually affect older patients and has been reported in dogs as old as 7 years. Again, predominantly large and giant breed dogs are affected, and I've listed the kind of overrepresented breeds for Panosteitis. Don't forget, though, that this can be identified in many breeds, just like hypertrophic osteodystrophy, and in fact, some of the smaller breeds, like beagle dogs, will also show up with clinical Panosteitis. It is interesting to note that males are affected 4 times more often than females. Now, interestingly, although the disease is called Panosteitis, this is not an inflammatory disorder. Histologically, there's an increase in osteoblastic and fibroblastic activity. This also is of unknown etiology. Perhaps this might have a viral etiology, but maybe metabolic or genetic, possibly endocrine dysfunction, or maybe even autoimmune. So again, not known, but some mechanisms proposed. This slide just reminds us of what the normal medullary cavity will look like in our long bones of our dogs. So here's a normal 7-month-old dog, both the humerus and the radius and the ulna. And notice that when we are near the physis and the metaphysis, there's always more bone opacity. This is where the bone is actively remodeling. It's called the cutback zone. And in fact, sometimes you may even see a little bit of a periosteal reaction associated with that small zone of metaphyseal increased bone opacity. And then the medullary cavity should be fairly uniform in its lucency, with good distinction between the endosteal side of the cortex and the medullary cavity. When we get down in the distal humerus, there will be, and even here in kind of this distal diaphysis, there will oftentimes be thicker trabeculae that you don't want to confuse for diseases. In the radius, again, nice and uniform lucency of the medullary canal with that increased bone opacity at the level of the proximal and distal metaphysis. Again, that's our active remodeling or cutback zone. Same thing in the ulna. Here is a normal young adult, so less than 2 years of age. Now our physes are closed. Again, I want you to just kind of get a feel for what that normal medullary cavity will look like, and then be sure to review it in the other long bones, the femur, tibia. Now, because this is a disorder with osteoblastic activity, we're actually looking for regions of increased bone opacity within that medullary cavity. Very early or mild findings might include blurring and accentuation of the trabecular bone as it becomes more opaque in the medullary cavity, but this part is oftentimes not recognized. Later, we'll see some diminished definition between that endosteal surface of the cortex and the medullary cavity because the medullary cavity is having areas of increased opacity or sclerosis. So the word sclerosis referring to increased bone opacity. And the more easily recognizable early or mild findings are circumscribed nodular regions of sclerosis or bone opacity in the medullary cavity. One thing to keep in mind is that oftentimes this likes to originate or be most pronounced near the nutrient foramen of the affected bone. As the disease progresses, chronic or more severe radiographic findings can include more diffuse and homogeneous areas of medullary sclerosis, so no longer kind of the circumscribed nodules. And then sometimes along the periosteal surface of the cortex, we'll actually get a solid periosteal reaction with smooth margins. This is one disorder where the radiographic findings can be almost pathognomonic for the disease, but if the patient is not responding to symptomatic therapy for pain control, then you probably should consider repeating radiographs to rule out the fact that there might be an actual less typical medullary infection. Again, we're seeing this increased medullary opacity because this has increased osteoblastic activity. Another thing to keep in mind is that the Panosteitis findings can be solitary, so one site could affect multiple sites within one bone, or they can be multifocal in multiple bones. And so sometimes these patients may have a lameness clinically that shifts from one limb to another. But the severity and location of the radiographic lesions don't always correlate with the severity of the clinical signs. So here's an example of a 5.5-month-old intact male German Shepherd dog who's presenting with lameness and has early or mild Panosteitis. So on the lateral view, in kind of the mid to distal diaphysis of the humerus, we can see this region of medullary sclerosis or increased bone opacity, and notice it's adjacent to that nutrient foramen. This would be why we start to lose definition between the endosteal surface and the medullary cavity because of that medullary sclerosis. On the craniocaudal view, we can also see that medullary sclerosis. Again, it should be uniformly lucent here, and here would be our normal, so this is too opaque. Here's another patient that has early or very mild Panosteitis, and the images on the left that are unlabeled show us that there is this very small, focal, almost circumscribed nodular region of increased medullary canal opacity that I can see a couple different areas here on the craniocaudal view. So this is probably another one down here. Don't confuse the normal trabeculation as the abnormality, but these areas are our medullary sclerosis. So again, this is fairly mild. Here's a patient that has much more chronic or severe Panosteitis. I just gave you the lateral view of the radius and the ulna. And if we notice the radius proximally here, this would be the normal lucency, and we have this more diffuse medullary sclerosis, then a little bit of unaffected, and then again, regionally affected medullary sclerosis. This patient also has mild periosteal solid reaction on the periosteal surface of the cortex, and then there are regions of medullary sclerosis from Panosteitis in the ulna as well. These are 3 different patients with various manifestations. So on the left is a little bit more early manifestation, and there's this well-circumscribed area of nodular medullary sclerosis in the proximal ulna, probably a small amount here in the mid-radius. Again, notice that is near the nutrient foramen. Here's a lateral view of a tibia in a patient that also has kind of mild to slightly progressed Panosteitis. So here's our normal lucent medullary canal, and as we get up near this nutrient foramen, we start to see these kind of nodular areas of sclerosis, and then it's more diffusely sclerotic up in the proximal diaphysis involving that medullary canal. And then the patient on the right has more chronic and severe Panosteitis, where almost the entirety of this medullary canal of the diaphysis of the humerus is affected with the sclerosis. And then here is a solid periosteal reaction along the caudal cortex. Again, here's our nutrient foramen. And then here is a dog on the left that's affected. I have lateral views of both stifles, left and right. Here is a normal dog, the stifle as well as the tibia, just for comparison. So this dog over here on the left side of the slide has a mild amount of medullary sclerosis here in the mid diaphysis of the tibia that is adjacent to the nutrient foramen. You can compare that to his normal side that is uniformly lucent. And then on this patient, there is more diffuse medullary sclerosis or medullary opacity throughout the diaphysis of this femur compared to the normal femur here. Now I'm going to notice a little sclerotic line here that is transversely oriented to the femoral diaphysis. That is kind of a variant that we might see. Those are usually called growth arrest or stress lines, and that's just a little area of bone that got deposited at a point of growing in this young dog. And so this normal dog over on the right side of the slide also has that growth arrest line. So again, normal for comparison. Be sure to consult the textbook chapter and the pages listed here for further explanation of hypertrophic osteodystrophy and Panosteitis.